Hello and welcome to the latest episode of Lovegrove on Health. My name is Dominic Lukes. I'm the Product Marketing Manager here at Skills for Health, and joining me as always is Andrew Lovegrove. How are you, Andrew?
Hi there, Dom. Really well, thank you. It's a lovely sunny day where I am today, and really great to be back here with you for this very special episode.
Yes, got a new dynamic for this episode of Lovegrove on Health. Our first ever guest. Welcome, Julia. I don't know if you just want to quickly introduce yourself.
Hi, my name's Julia Taylor. I'm an advanced nurse working in primary care and have worked with Skills for Health on various frameworks now in the past. I'm also a GP training programme director in the Midlands. So lovely to be with you.
Oh, no, thank you for joining us and for taking the time out. I know you played a pivotal role in chairing the working group for a recently published General Practice Nursing Education and Career Framework, which looks at how the nursing profession and their roles can be supported to meet changing needs and demand. But let me hand over to Andrew now, who's going to give a bit more of an introduction and background to the podcast today.
Thanks, Dom. And yeah, today we're really grateful to Julia for being here. So thank you from myself, Julia, for joining. And I think we've done several podcasts where primary care has been a recurring theme and a topic. And I think that's because, so much of healthcare takes place in that space. Primary care is the linchpin of the NHS. It's where the vast majority of people are seen, looked after, cared for, and it underpins everything else within the health sector. So it's not unsurprising why we keep coming back to it as a subject topic. But what we wanted to do today was bring in people such as Julia, who've got some, real lived recent experience of what primary care is like. And so today's podcast, we're going to perhaps just explore and hear some of those challenges, but then talk about a new framework that was launched recently and how we see that helping the primary care workforce moving forward to help perhaps remediate and deal with some of the challenges that it's facing at the moment. So that's sort of a bit of an introduction for today's session. So Julia, if I can come to you next, I'm really interested to perhaps just get your thoughts on what it's been like at the coalface and what's been the experience of primary care in recent times.
Well, I think the first thing to say is the effect of the pandemic on primary care. It really did turn everything upside down and inside out and changed our ways of working completely, pretty much overnight. And some of those things, I think, have been hugely helpful, and some things have been more challenging. So one of the primary things that we've got better at, I think, generally is technology. We are better at consulting over the phone. We've got video consultations, email consultations, as well as face-to-face now. So we've become much more proficient in offering more choice, really, to our patients. The other thing that we have is the just increasing demand, really, both from patients and the public, and because of just the service needs and the service demands. More and more work services are coming out into the community. More is being diverted away from the acute trusts. There's far more focus on health promotion and population health and preventative work. So we're being stretched, I guess, being asked to do more. The population's growing. There are more people with more complex conditions, lots of multimorbidity. So it can be quite a challenging environment to work in. You never know what's coming through the door, but that can also make it very interesting and worthwhile too.
Yeah, and I think there's been some short-term challenge, which has been COVID, which effectively required primary care to change almost beyond recognition overnight. But actually, I think it responded well. On the whole, it responded well to that challenge. So it just shows the expertise, the skill, the resilience within primary care. But I wonder, some of the things you were just then talking about, they're more long-term challenges for primary care because, as you say, we have an ageing population. I was NHS Confed in Liverpool, and one of the statistics that was mentioned was a typical 80-year-old puts 3 times the amount of demand into the health system than a typical 50-year-old. And so as the population is getting older, we're living longer, which are good things. I just need to say that to be absolutely clear. That comes with additional challenge for health, and probably where that is experienced the most is within the primary care space.
Yeah, absolutely. And it is about managing, I think, people's expectations of having a long, healthy life is what we all want, really, to be able to make the most of the time that we have while we're here. And the GP and general practice primary care is very often the first sort of way of accessing or finding out information or advice. And one of the things that we are obviously aware of is the work that's going on to support the development of primary care teams and wider, to share that out, if you like, and give patients other options. In the past, the GP has been almost the first person that you pick up the phone to, and that needs to be shared now because of just capacity issues. You have a wide range of patient numbers depending on the practice that you work in. We've got practices coming together as large PCNs, so they're becoming very large organisations. The practice I was working at had about 44,000 patients. That's a huge number of patients. We'd be getting over 3,000 calls a day into the call centre. That's a lot of telephone calls to manage. They're all wanting, expecting something. Not always an appointment, sometimes information, forms to be filled in, all sorts of things. But that's a lot of contacts to be handling. We've got, as I said, a developing workforce. We've got our GPs. We know that a lot of our GPs are retiring and leaving, and that we need to be recruiting and training more. We're doing more to increase the amount of doctors in training, and then also GPs in training. And then also all of the work that's going on to try and increase the amount of nurses in training and AHPs. Nurses are the second largest workforce within primary care, and many of us are reaching a certain age, which I won't specify. So we need to be looking at how we promote primary care as a career option for all of the multi-professional team, really, and look at how we can work differently to enable things to progress in the future.
Do you think, Julia, we'll come on to sort of talk about workforce a little bit later. I guess thinking about primary care, somebody said to me once that almost primary care has become a victim of its own success, that for many years, we've had a model that's been quite perhaps paternalistic in the way it's been set up, and the way we almost have an expectation that, doctor will put it right, and that we have a problem and primary care will sort it out for us. And as we age, as we grow in number, that kind of model is not sustainable, both from an economic perspective, but also it doesn't make sense from a public health, from a population health perspective. So do you think one of the challenges is that we're moving, there's a sea change occurring now? Ideally, change happens at the best possible time, doesn't it? But we're almost doing it on the back of, or COVID brought it to a head. The need to change has been brought about because of the crisis. So we're perhaps not doing it in the ideal time, but that need to change to depaternalize healthcare. Do you think that's something that's in the mix that's affecting primary care at the moment?
Yeah, definitely. I think that it's a historical thing. You look at how general practice was in the past. You had a GP that had probably brought you into the world and was with you for a large part of your lifetime. You knew them, you would expect to see them the same time every time you contacted the surgery. And because of how things have developed, that really is quite unusual now. We've got more and more staff, as I've said, working in, and the expectation is different. Sometimes people are unsure about who to contact, and say the general practice is the first thing that they contact, and actually it's inappropriate. So there's a lot of signposting that's going on. But yes, we do need to be trying to shift the power back to patients and the public and give them ownership of their own health and well-being. There's far more to be managed, not only in terms of physical health, but mental health, that kind of psychosocial wellness of everybody. So encouraging people to really take ownership of that themselves, and to be looking at what they can do to support their own health needs and to keep themselves in the best possible shape that they can going forward.
And I guess from another perspective, the challenge of people who, I suppose, kept away during the crisis. They didn't present that thing that's not going away, or that lump that's getting bigger, or that pain that isn't going after a couple of days. So we're dealing with people who need to be seen and need to be seen quickly, but obviously complex patients require complex multiple interventions. So it's another layer of challenge for all of the health sector, but because we enter at the primary level, that's where it's probably felt most acutely.
Yeah, and there's a range, isn't there? So as you've said, Andrew, we've got people that haven't wanted to bother us over the course of 2 years and have sat on symptoms that maybe they shouldn't have done, and we're now playing catch up, encouraging those people to come in and be seen and to refer them on. And secondary care are playing catch up because they've had to postpone so many things. Their waiting lists are very long. So you've got that going on. You've got people that, from that side, that, as I've said, will sit on their symptoms and not want to bother you. You've got other people that wake up that morning with a sore throat and think they need to ring you immediately rather than wait and see if it gets better. So you're managing that type of demand and trying to support people to look after themselves and to make some choices around their own lifestyle and well-being and health. And we've historically had 10-minute consultations. Trying to manage somebody with multiple problems on 15, 20 different medications within a 10-minute appointment is a really tough ask. And I think one of the things that we're going to have to look at is whether we work differently. And certainly there's lots of conversations around whether we should have different length appointments and maybe try and manage some of those more complex scenarios in a longer appointment where we can do it better and complete that episode of care really well. And hopefully then almost cut down on saying, well, actually, we've not really got through to the bottom of that in 10 minutes, and you're going to need to come back for another appointment and then possibly another one. But it's a sea change. It's very different to how we've worked in the past.
It is, and I reflect on my own experience with primary care. I have asthma, so I have a long-term condition which I've had virtually all certainly my conscious, I can remember life. And being a nurse by background, I suppose I flatter myself that I am an expert patient with my condition. And for years, I've had almost this battle royale with primary care that, you must come into the surgery once a year, you must be seen, we must do these things. And I've often come away from that appointment thinking, well, I hope they got something out of it, because I didn't really get an awful lot out of it. But since COVID, that's now moved to a telephone consultation. And then this year, I was asked to complete a short questionnaire, and I filled it in. And because my condition is well managed. It is under control. The medication I'm on does work. They've said, we don't need to see you, but if your symptoms do change, if there is a change in your overall outcomes, then get in touch with us. And I thought, brilliant, because I've often come away from appointments feeling guilty. That's a 10-minute appointment that someone hasn't had because I've had to have my sort of annual MOT. There are absolutely patients who do need to be seen face to face, but it's been a great experience for me, and that's as the end user in all of this. So that's something I think that's to be applauded, really.
Yeah, and I think many patients, that example you've just given there, Andrew, for many, they absolutely love it. They love being able to sort something out over the phone or via an e-consult. But you will always get patients that want to be seen face to face, that have their own preferences, and that's fine. And what we really want to be able to do is enable choice. But again, some people that want to be seen over the phone, we have a hard job of convincing that actually we think they need to have a face-to-face examination. So again, it's about educating the public about some of the things that can be managed safely over the phone and the things that need to be seen urgently or routinely, whatever. But the rationale for that and having a shared management plan with our patients so that they understand what's going on.
Yeah. I think there's two key words that are coming out, Julie. I think choice is something you've just said, which I think I completely agree with. But I think with choice comes responsibility, and actually being, I am responsible for my health and well-being, and contributing to that, as well as the doctors and nurses in my local GP surgery. They are not wholly responsible for my health outcomes. It's about working together. It's about partnership. It's about responsibility and an element of choice.
Yeah, no one can do it for you. You have to take some ownership yourself.
Yeah.
And I think one of the challenges that we've had when we went at the beginning of the pandemic to purely telephone appointments, it meant that actually we could do more of them. So our capacity went up. And then as we now shift, practice is shifting back to offering some face-to-face, it actually means that you can have less patient interactions because it takes longer. So it really is hugely demanding. And as I said previously, the call centre where I worked would have sometimes 3,000 plus calls a day. That there's no way that the 18 or 20 clinicians in that day can manage 3,000 appointments. I'm not saying they all want appointments, but even half of that. So it's a huge number. So yeah, back to patient responsibility, public responsibility, choice, but sensible choice with some guidance and some parameters around that. It's really important. It's all around education.
Absolutely.
We've got lots of patients like you, Andrew, that have their own conditions and have become very efficient at managing their own symptoms, know the red flags, know when they need help, know when they need to contact somebody. So having a really good shared management plan with those patients and allowing them to be able to manage themselves as best they can and trusting that they know when to contact us. And if they do contact us, then they're very likely needing to be seen is a huge help as well.
Yeah, absolutely. I wonder if we could probably move on to talk about some of the workforce challenges, Julia, in primary care. I mean, I think you don't have to go many days before picking up a paper which talks about the crisis, particularly with GPs. A lot of them are choosing to retire if reports are to be believed. I say that because some of the newspapers I read don't necessarily always report things as accurately as we perhaps would like. But as an ageing population, we've got an ageing workforce. And I suppose my initial question moving into the workforce space is, have you seen, I mean, there's always been starters and leavers, that's nothing new, but do you feel that more people are leaving than ever before as a percentage? And if so, do you think we can attribute that to certain things, or is it just a headline that's newsworthy?
I think it's probably a mix. I think we do have an ageing workforce within primary care generally. We have the ways of working different, whereas before we would have doctors that would work full-time in the practice, seeing patients all day, every day. And that's less common now. There tends to be more portfolio careers around. Many staff work part-time. They might see patients a couple of days a week and have a special interest where they're doing some musculoskeletal work or working as part of the PCN or involved in medical or clinical education of some description. So it's a much more varied career option, which is great, and it enables us sometimes to retain staff for longer because they have some variety to their working week. Because actually working full-time at the clinical coalface is really quite tiring. You're having a lot of patient contacts a day. As I said, you never know what's coming in through the door. You have to be on top of your game in order to make a safe assessment, make sure that you're picking up on any red flags and managing people appropriately, not to mention all of those interpersonal skills that you need along the way to be able to support your patients so that they can go out and be happy and healthy and well. So it is hugely demanding. So I think that those are all contributory factors, really. It can be very difficult to get people into university at the other end to start studying these courses. Sometimes the demand is high to get into these places, but there are limited places, and we do need to have a standard, obviously, as people come in, but it has been, it's a change to what it was before. And I think what I'm seeing in my role as GP training program director is that most of the GPs, when they qualify, want a part-time job. Most of them will do 6 sessions a week, which equates to 3 days. Some will do 8, but it's very different. You don't get them coming out wanting to do full-time, sort of 5 days a week in general practice. Full-time hours really is 8 sessions over 4 days. So you need more of them to cover the days of the week that the practice is open. And we have now, as well as the core hours, you've got extended hours where we're trying to cater for people that want to come before work and after work. So there are more hours to be covered as well. So it is challenging.
Yeah, you've got a bigger piece of bread with that needs covering, but the butter doesn't quite spread in the way that it once traditionally do. So I probably stretch that metaphor more than it can possibly bear, but I think it's really interesting that that traditional way of the workforce working at the same time as the needs of the service are changing creates a challenge. But also, I think what I'm hearing there, it also creates some opportunity as well for people to have those, as you said, those portfolio careers, that it's not necessarily an either or position, that you can be clinically facing X percentage of the week. You can do something else X percentage of the week and have a more rounded, fulfilling experience at work.
Yeah, absolutely. Huge potential to be able to find a special interest that really floats your boat and makes you passionate. So there are many opportunities. I just wanted to reflect back on something else, actually, that has been a challenge for many, is premises and rooms available. It sounds strange, but we've got many general practices, you think back, were set up in a little terraced house somewhere with a couple of consulting rooms. And I think most practices, we've got a lot now moving into new builds. But as soon as you move into a new build and you think you've got plenty of space, it doesn't take long to realise that very quickly you're short of consultation rooms. And that's one of the challenges in terms of growing the multi-professional team and bringing more people into primary care. Where do we put them? So I just wanted to reflect on that.
Yeah, I was just going to say, I think it's a good point, Julia, because when you've got more people in, then they require their own space to see people appropriately and safely. And you're right, I'm just thinking about my own practice that was a terraced house that had an extension, that had an extension, that had an extension. And you almost need a route map to navigate your way around the building because it doesn't actually make sense. It's kind of like the TARDIS. You walk in and you think it's X size, but then it all goes off and you can almost see the different styles within the building. When certain styles of room are in fashion, then they move out of fashion and it dates it very quickly. And, it creates a real challenge. I'm quite nosy, or if there's a conversation to overhear, I'll pick up on it. And I remember two receptionists talking, oh gosh, we've got a room clash. What are we going to do? Because there was literally two back-to-back consultation sessions that needed to run and there was only one room available. I wasn't quite there for the conversation, how they resolved it, but as you were reflecting on estates, I was just reflecting on my experience as well.
But again, that's something that can be helpful with telephone consultations. If you've got a practice, you're short of rooms, well, you can run a telephone surgery from somewhere private, but it doesn't have to be a clinical room. So that can help with some rooming. But yeah, the person doing the rota and the rooming in primary care has probably got one of the toughest jobs. So it's a constant challenge.
Absolutely, and we need to give credit to those because they're one of the unsung heroes that we, as patients, we're not aware of and don't necessarily recognise what they're doing. If I can move us on, because I really want to talk, Julia, both the thing that you and I have in common is that we are both nurses, although I'm no longer on the register. I'm interested, you talked about, nursing being the kind of like the, after GPs, the largest sort of professional group within primary care. And that's been on a journey. I can remember, I am old enough to remember when practice nurses were new, and I was a teenager, I think, and my surgery had a notice up. I'm going really old school now. I think it was handwritten, which explained what this new practice nurse was and what they could do. And, in a couple of decades, 2 or 3 decades, we've gone from this is new and slightly, uncharted territory to how could primary care survive without them? And, you'll have lots of experiences, the highs and lows of working within primary care. But I suppose what I want to get to is we've talked about some of the challenges of working in primary care, but almost let's put our glass half full hat on. What do you think are some of the good points or the opportunities of working in primary care, based on your experience and from what you know from other nursing colleagues?
Yeah, I think it's amazing when you reflect back that, as you've said, Andrew, nurses came in to essentially help the doctors initially with task-orientated stuff, I would suggest, in the very beginning. And when we look at how that has evolved over the years, it's incredible. So that's one of the beauties of general practice in primary care, is that there are opportunities to look at how you can do things differently. You have to be able to look at what the service demand is in your locality, look at the resources you have and think outside the box. You may need to develop different services. We know that traditionally our general practice nurses have done brilliant work in terms of long-term condition management, immunisation, all that kind of stuff. but now we are looking to, as I say, do things differently, working with our social prescribers. We had a lovely example last week where one of the general practice nurses at a PCN had set up a drop-in centre, because we know about the statistics about being lonely. Being lonely and not having contact actually has a very detrimental effect on your physical and mental health. Surprisingly, the amount of the effect it has on your physical health, and being able to make some changes with that, some positive changes within your patient population, actually reaps benefits. And that was something that a group of practice nurses have set up as a result of the pandemic, and it's been hugely successful. It's given them a bit of something different in their working regime. They've been able to lead on something and see the benefits of it, and it spurs them on to look at different things. So don't feel, one of my key messages, I think, is don't feel that you get a job in primary care and you have to do that job in the same way every single day for the whole time that you're there. That the service needs need to be met. You have a finite amount of resources, so you have to work as a team, but you can think flexibly and be able to be a bit inventive, I think. So I think that the opportunities there can be massive.
As you were talking then, Julia, I was reflecting on my own sort of professional life. I obviously, as you know, I became a health visitor, and one of the reasons I wanted to work in that community space was, my desire to not be bound in perhaps the same way as one can be, or at that point we're working within acute care. I wanted to be able to innovate. I wanted to be able to do things in a way that I felt worked best, or having assessed my patient population's need, to tweak or enhance the way I did things. So I think working in that primary community space, if you are an innovator, I think that's a really great place to go and innovate. And I think that's a real curb appeal of working in primary care, notwithstanding all the challenges that we've talked about at length already. But I think I call it a challenge, but I think it has the potential to be a real rewarding challenge.
Absolutely. And we've very much been focusing on clinical stuff, because obviously that's hugely important. But we have opportunities now to work in leadership roles and to be involved. We've got nurses that are clinical directors of PCNs, which is fabulous, leading nursing and multi-professional teams. We've got the opportunity to be involved in education and supervision of others, to be able to encourage the workforce development around us, be able to share our expertise and offer support to others as they develop within their careers. Even being involved in quality improvement work, looking at how you can do things better, improve patient pathways, working across systems. We're now looking at the development of integrated care systems and integrated care boards, where things are going to join up more, hopefully. Some of the boundaries will be able to be broken down. So there will be roles for looking at how to do that. How can we join things up? How can we approach how we do things better and improve the patient journey? So there are far many more opportunities alongside those traditional clinical ones that I think we need to grab with both hands.
And I think that leads us nicely, Julia, to talk about probably what brought us together as colleagues. And we've worked on a couple of frameworks together. I think the first one was back in 2019-ish, when we developed a capabilities framework for advanced clinical practice for nurses working in general practice and primary care. And then more recently, in fact, a framework that was launched just shy of a month ago was the General Practice Nurse Primary Care Career and Capability Framework. And so, you chaired the steering groups for both of those frameworks when they were in the development process. But obviously, we've launched them now. They're now out in the system. What are your hopes? We've done the framework work now. Now that they're out there, so I've got two questions for you. What do you think the value of those frameworks are now that they're out there? And what are your hopes? If we were to measure the success of those frameworks, what would that success look like? What would be some of the metrics that we could use to identify the success of those frameworks?
Okay, so I think that firstly, the career framework was hugely needed to reflect the more recent changes. So we needed to include TNAs and nursing associates. So this framework went from support worker level right the way up to consultant level practice. So it allows people to see the opportunities within primary care. You've got general practice nursing sitting within that. That crosses quite a few levels of practice, but there are other opportunities as well. And we certainly wanted to include the wider nursing family. So our mental health nursing colleagues, learning disability colleagues, paediatric nursing colleagues, not just general nursing. So really wanted to make sure that the wider nursing family were aware of the opportunities within primary care. So I hope that it's hugely valuable to nurses themselves to be able to see the capabilities and the opportunities for development, but to celebrate what they do. We're not very good at doing that, I don't think, as a profession. And actually seeing it written down on paper is quite amazing, really. And I think that having that will be helpful for appraisals and for role development, staff development, for looking at how you can take the capabilities in that framework to design a role. The framework doesn't tell you roles, it tells you capabilities. So it's not restrictive. It's there for people to be able to look and say, well, we could do with a nurse working in this way. What kind of capabilities would they need? And be able to pull from the framework and develop a role or a post that would be appropriate to meet the needs that they've identified. Also hope that the framework's useful then for workforce planners and for employers and providers so that they can see what nurses can provide in terms of knowledge, skills, and behaviours and capabilities within primary care. So I think that's really key. Patients and the public can see also. So I think it's really handy tool, if you like, to be able to really flag up what nurses can do within primary care, as well as being a practical tool. We work very hard on the layout of the document so that you could look at a page and see the progression without having to flip back and forth through lots of various bits and bobs. So I hope that it's practical and that people will embrace it to support them in being able to develop services within the primary care setting. Does that answer both of your questions, or just one of them?
I think, Julia, you've summed up the whole raison d'etre of the framework there really, really well. I think one of the things it does is show the spectrum of the kind of the career journey that is open to the nursing workforce in primary care. And there's a lot of myths that become believed reality. I still hear pre-registration colleagues saying, oh, you must work for X number of years in an acute setting before you can go and work in primary and community care, and there's no roles for the support workforce in primary care, or once you get into primary care you've hit a glass ceiling and there's nowhere for you to go. And I think what our framework does, and we've managed to achieve it on 3 sides of A4, is succinctly but clearly demonstrate that you can enter at various levels and various entry points to working in the primary care nursing workforce, but at whatever point you enter, there is growth and room for development upwards, but also, as we were saying before, given the innovation within primary care, people who are happy working at a particular level of practice, they can grow and develop and enhance their practice at that level. So there's kind of horizontal growth and development and vertical growth and development. And I think the framework is it's got a lot of curb appeal to show the nursing workforce, there is a role for you in primary care. And I think it's a great piece of work that does that. So that's kind of like the front cover, but then the capabilities are where that some of that detail is. For example, to do that workforce development, to do that role design, to do that workforce planning, to enable patients to be able to see what they can expect from the nursing workforce, to be able to map service growth, service demand, service analysis against the capabilities that this hugely important workforce have. So I am biased, but I think it's a fantastic piece of work, and I just want to see it promoted and used out there, quote unquote. Now that we've done the development work, it's launched, it's out there. Let's use it, people.
Yeah. And I think absolutely it's a career framework, but we need people at every level. Every level is important, and every level can add huge impact and can do things creatively with the support of their employers, obviously. So I think that's hugely important. And I think it's also worth just flagging up that it's a capability framework and not a competency framework, and that is different. It's not, you've got this skill and someone's seen you do it once. It's being able to have a piece of knowledge or a skill or a behaviour, and you'll be able to apply it flexibly in different contexts. That's really, really important. It's not all about academic knowledge. Capability is really important as well. It's about how you apply your knowledge and skills day to day in the room, on your own with the patient or in the patient's home during a visit, etc. So that flexibility and being able to apply things appropriately is really, really important. And I hope that the capability framework really captures that.
Absolutely. And there, for listeners out there, there is actually a section in the framework that articulates what Julia's just said, competence versus capability. But I think, Julia, you've just summed that distinction up really well there for our listeners. Just conscious of our time, Julia, is there anything else that you'd like to say about our work, about the framework, before our time draws to a close?
No, I think would just encourage people to have a look at it, and not to think, another framework and sling it in a drawer. It has been there. See it as a supportive document. As Andrew said, if you wanted to move into primary care from another setting, you should be able to look at that framework and have an idea about what capabilities you have and where there might be gaps, and see what sort of level of support you might need if you were transitioning in a role. So it's there to be a supportive document and to help people sort of meet some standards, and to celebrate and recognise the work that they're doing, and also to enable the primary care nursing workforce in developing going forward. So please grab it with both hands and use it to improve patient care, service provision, and as well as your own career, to hopefully give you some really good job satisfaction and career development.
Great. Well, thank you so much, Julia, for joining us today as our special guest star for Lovegrove on health.
Yes, thank you, Julia. That was a wonderful insight into life working within primary care, especially during and post-pandemic. I'm sure that would be fascinating listening, especially to those working in that area. Lovegrove on Health will be back on the airwaves shortly. Andrew's on another cruise. It's far too much holiday. But a reminder that you can subscribe to our podcast from wherever you get your podcast from. They're on all the major platforms. And thank you again for listening.
Bye.